All right. Well, good evening, everybody, and welcome to this session of Therapy Ed's online office hours. Appreciate all of you joining us, and got still a number of people that are checking in. But it is right at the top of the hour, and 7 o'clock Eastern Time, 6 o'clock Central here. I'm here in Central Time in Texas, and so we are going to get started. Um, you'll note and as y'all are checking in and everything, just please remember to mute your microphone when you enter the Zoom room. If you want to ask a question later, you can certainly unmute it, or if you want to raise your hand to chat, that'd be fine as well. This session is going to be recorded to Therapy Ed's PT, the YouTube or Therapy Ed's YouTube PT channel. And so if you want to be able to go back, if you want to go back and take a look or review some of the information that we covered tonight, then you'll be able to do that. Um, for this evening, what we're going to do is we're going to talk about disorders of the elbow, forearm, wrist, and hand. I'll tell you a little bit about the premise and the idea behind covering that as a topic in just a minute. But let me go ahead and introduce myself, share a little bit about my background. My name is Tom Sutlive. I'm on faculty in the Army Baylor University DPT program here in San Antonio. The image that you see in the bottom right of the slide that's currently on the screen is actually just outside the building that I work in. The building that I work in is actually in the background to the right. So that's where the Army Army Baylor DPT program is located here in Fort Sam Houston in San Antonio, Texas. I've been on faculty there for about 25 years. I'm currently actually the chief of the anatomy, physiology, and pharmacy branch. So I do a little bit more than just teach into the DPT program. I teach into OT program and nursing anesthesia as well. You can see on the slide a little bit about my education background, and I've been a therapy ed instructor since 2011. I became an editor for the review and study guide that we published several years ago. And I love what I do. I love working with graduate students like yourselves, and I'm looking forward to spending the next hour with you all. Let's go ahead and let's kind of get the the chat room lit up a little bit, and if y'all could go ahead and chime in and answer. When do you plan to take the NPTE? I assume that a number of you are going to be taking the exam about a week from now. Okay, good. So yeah, so this is exciting times, right? We're on the home stretch, y'all. Some of y'all are going to be taking the exam, I think maybe as early as Tuesday. So Tuesday, Wednesday, Thursday. Some of you are taking the examination. Not until 2026. So there is no substitute for early preparation. So we got quite a range, but looks like the majority of you are going to be taking the examination next week. And so we're going to try to get some repetitions in and answer a bunch of practice questions and help you get ready for the exam whenever you're taking it. The Yeah, as far as the topic goes for tonight, we're going to talk about disorders that involve the elbow, forearm, wrist, and hand. But really, what we're going to do is we're going to focus on the musculoskeletal system, and we're going to focus on the neuromuscular system as well. And I think we're going to answer about 7 or 8 questions, or I've got about 7 or 8 practice questions. And as we review those questions, we're going to review important examination, differential diagnosis, and intervention concepts and principles. And rather than me present a topic for maybe about 20 minutes or 30 minutes, which is sometimes what we do, we're just going to dive right in and start answering some practice questions, and then we'll review the important content along the way. I think it's always helpful to just kind of, to review what what the content outline looks like. And what I've presented to you here, what you can see on this slide is just the content outline as it relates to systems. Of course, there's all the non-system categories too, like research and EBP and equipment and devices, therapeutic modalities. But since we're focusing on the elbow, forearm, wrist, and hand today, I thought it'd be best to go ahead and just present this slide that shows the systems. And we know that the musculoskeletal system and the neuromuscular system are going to be the two largest systems that are represented on the NPTE. As a matter of fact, on this slide, you can see the big three. So 65% of the examination is going to be made up of questions based on the musculoskeletal, neuromuscular, and then cardiovascular and pulmonary systems. So 2 out of every 3 questions. And no doubt, those of you that are going to be taking the examination next week, you're in that kind of period where you're going to do your final review and polish. For the rest of you to have a little bit more time, if you're taking the examination in October or you're not taking the examination until 2026, a big chunk of your time needs to be dedicated to studying the big three. And so really two out of every 3 questions that you answer on the examination are going to be based on these categories. We don't want to forget the smaller systems, and the smaller systems comprise about 22% of the examination. You could have questions that deal with the elbow, forearm, wrist, and hand, upper extremity disorders that are based on some of the smaller systems, like, for instance, the lymphatic system. So dealing with somebody working with a patient that has lymphedema, or answering questions about that, or the integumentary system. Maybe somebody has had burns that involve the upper extremity, or some type of skin disorder. But what I've chosen to really focus on tonight is going to be the musculoskeletal. So let me just kind of gray out some of these other systems that are listed on the right. We're going to focus on, disorders that involve the musculoskeletal neuromuscular system. And you can see them listed here. So fractures, ligament injuries, tendon injuries. We know that RA and OA can affect the hand and the wrist, and post-op rehabilitation. Maybe you'll get questions that deal with somebody that has had a tendon repair. And so you'd certainly want to make sure that you review those principles in preparation for the exam. As far as the neuromuscular system goes, peripheral nerve lesions. So maybe lesions that involve the median nerve, the radial nerve, the ulnar nerve. We're going to see some of questions that relate to some of these topics tonight. Radiculopathies as well. Maybe something a little bit more complicated, like brachial plexopathies or demyelinating disease. And then, I've got the other categories on the right grayed out already, but we know how, for the cardiovascular system or lymphatic system, lymphedema would be a consideration. Diabetes, we know that in terms of sensory impairments and polyneuropathies, we see a stocking and glove type of distribution for sensory impairments. And I mentioned a little bit earlier, so burns and disorders that involve the skin. But we'll focus on some of these topics that you see in the bolder font that is listed on the left side of the slide. And really the whole premise for this presentation tonight, and the reason why I decided to make sure that we cover disorders of the elbow, forearm, wrist, and hand is because, and I don't know what your experience has been like in the clinic to date. I can tell you, as a person who's spent many years in the clinic, and primarily in a military setting. I was a I served on active duty in the Army as a physical therapist for about 23 years. And what I saw in terms of military PT, but I think it's very consistent with what most of y'all have probably experienced too, is if there's a disorder that is distal to the elbow, then we're often going to think OT's got that, right? The occupational therapists they're going to take care of that patient. But you've got to know this information for the NPTE. You are going to see patients in the clinic that have disorders of the elbow, forearm, wrist, and hand. And it wouldn't surprise me if a number of you went on to become certified hand therapists, and you really specialized in working with patients that have disorders that involve the distal part of the upper limb. So with that, that's kind of the premise for this evening. And the other thing that I want to highlight is we got to make sure that we're good at picking up on things like fractures and acute ligament injuries and things that need to be taken care of in a timely manner.
Progress.
To remember to, y'all to mute your microphones, and for those of you who just joined, and but the whole purpose of the NPTE and what the FSBPT wants to focus on is to make sure that not only are the new PTs that are entering the workforce, not only are they knowledgeable and competent providers, but they are also safe providers. So safety is going to be an emphasis throughout the NPTE, and that could involve recognizing problems that include the elbow, forearm, wrist, and hand. And so with that, let's jump right in and let's go ahead and start answering some questions. What we will do is I'm going to give you about 1 minute to answer each one of the questions. 30 seconds or so after you've started reviewing the question, I'm going to pop up a poll, a Zoom poll, and you're going to be able to chime in, answer the questions, and then we'll see how everybody responded to them, and then we'll go ahead and review them. All right, and we'll talk about some of the important concepts. And so with that, let me get my timer on my phone ready. And here we go. Here is question number 1. All right, and here's the poll, so y'all can go ahead and start answering the questions when you're ready. All right, so actually I meant to let me go back just a second, and I forgot that I got some of these on a timer. So Heather, you asked the question, are all these questions taken from the therapy ed practice tests? Some of them are from our course, and then some of them are going to be ones that should be relatively new to you tonight. So the fact that you asked that question, you may recognize this from one of our practice examinations. And so, yeah, some of the questions may be familiar, but hopefully you're going to see some new ones as well. So I'm going to go ahead and share the results. Everybody should have had time, plenty of time to answer the question. And let's go ahead and highlight and take a look at some of these key words. And we know, so this PT examines this patient. They sustained an injury to their ring finger while playing football 3 days ago. And the examination findings are consistent with a rupture of the flexor digitorum profundus tendon. Anybody know what the eponym or what the nickname is for that? If you rupture the flexor digitorum profundus tendon, there's a nickname that we think of, right? And so not mallet finger, but it is, Amanda, you are correct. And a couple of you also jersey finger. Yeah. So mallet finger would involve the extensor mechanism. Y'all can see the correct answer to this one is refer the patient to a hand surgeon. This is something that we would want to get taken care of in a timely manner. Shannon, you're asking about, wouldn't you want to do active range of motion first? I'm a little bit confused. No, in terms of the examination findings, if we identify the fact that the person has a rupture of this flexor digitorum profundus tendon, then we're going to go ahead and refer them to a hand surgeon. We're going to get them taken care of in a timely manner. And this would be one of those safety-based questions this that you'll see pop up on the examination. So there's this article. Some of y'all may be familiar with this article that is published called "Four Hand Injuries Not to Miss in the Emergency Department," or if we're thinking about practicing in an acute care setting or a primary care setting. And we're going to talk about most of these tonight. An excellent article, so y'all can either well, this session again is going to be recorded, so you'll be able to access this reference when you review, if you choose to review the YouTube session. But yeah, one of those injuries is going to be jersey finger, right? And that's what we've highlighted with this question. Now, I'm sharing a journal article with you. I think you all know that the examination that you're going to be taking is going to be based on textbooks, but all this information would also be published in textbooks. It'd be things in things like Dutton's Orthopedic and maybe McGee and other textbooks as well. And so Amanda, I see your comment. Surprised that a scaphoid fracture doesn't fall into this list. It may be that from the author's perspective, that the scaphoid fracture is a little bit more clear and easily recognized compared with some of these other injuries that are on the list. They may be a little bit more subtle, and also, in addition to a scaphoid fracture, would require that timely intervention. And so some of y'all yeah, so Maddie, good question. We have a Fuchs injury, which carpal bone is most likely to be affected. So it would likely be the scaphoid, but the lunate can be involved as well. And so y'all hold on to those questions, because we got many more questions that you're going to answer, and you're actually going to see a question that involves a Fuchs mechanism, and you may potentially see something that involves the scaphoid and lunate as well. Okay. So to review real quickly with jersey finger, yes, so the flexor digitorum profundus tendon, we know that it attaches to the base of the distal phalanx. It runs through that little buttonhole, as we call it, in the flexor digitorum superficialis tendon, and it makes its way all the way down to attach at the base of the distal phalanx. The ring finger is often involved just because when we grasp, for instance, when a football player goes to tackle or get a hold of the jersey of an opponent, or a rugby player goes to get a hold of them, it just tends to be fairly prominent as far as our grip goes. And there's this violent moment that happens, right? So we got a hold of the jersey, the opponent kind of breaks away, and there's this violent moment that can either lead to rupture of the tendon or an avulsion fracture at the base of the distal phalanx. And that's what we're seeing in the image that is on the left. This citation you can see down at the very bottom is all the way back from 1977. It's an old reference, but it's still a timely one. And the whole point of this question was we need to remember that we've got to make sure that we take care of these injuries in a timely manner, right? Because of the vascularity and the potential for the tendon to retract and loss of blood supply and those kind of things. So our what we're going to do is make sure that we get this person referred immediately to a hand surgeon, to an orthopedic surgeon. All right, let's go ahead and move on and let's answer number 2. So there's a poll. Y'all can go ahead and start chiming in when you're ready. Yeah, I forgot I had these on a timer so y'all can see some of the keywords that are popping up there. And let me just unhighlight them. But most of y'all have already answered this one. So we'll go ahead and move on. I'll share your responses with you. So it looks like it came down to either answer number 1 or answer number 2. Great job on that last question, by the way. I think 81% of y'all got that correct. So well done. On this one, we know that this individual, that they sustained the elbow dislocation while completing an obstacle course a few months ago. And the patient was immobilized for a period of time, several weeks, and now they present to the PT clinic with limited elbow flexion. So which joint mobilization technique is going to be best to improve elbow flexion? And what's going to come to mind are things like the convex and concave rule. We're going to review that in just a minute. And so the correct answer on this one is going to be what most of y'all chose. So about 70% of you chose anterior glide of the ulna on the humerus. If we're trying to improve flexion, then that is going to be the mobilization direction that we want to choose. Here's a quick review of the anatomy from Gilroy, and we've got with the elbow joint, we're thinking about the articulations. We got the articulation between the trochlea of the humerus and the ulna, and then the capitulum or capitellum on the humerus and the head of the radius. And in this case, what we're looking at, oh, and I wanted to bring this to your attention as well. So from our course manual, so for those of you who have gone and taken our 2-day course, you may recognize this, but we have put together a nice table that says, given a joint and the motion that you want to increase, this is the mobilization that you're going to perform. So you've got that information in the course manual. It's available to you if you've taken our prep course. If not, we're going to come back to the rules of convex and concave. And on this question, the convex surface of the humeral condyles would be fixed, and the concave ulna, the trochlear notch, or the radial head, kind of a shallow depression there, would be mobilized. So to increase flexion, we're going to move the forearm, the radius and ulna, in an anterior direction. All right. So certainly arthrokinematics, the rules of convex and concave, that's going to be something that you're going to want to be familiar with in preparation for the exam. And so again, well done. About 70% of you all got that one correct. As far as the answers go, yeah, let me just run back to those real quickly. So posterior glide of the ulna and the humerus was the next most popular answer. And of course, that'd be something that we'd want to do if we were trying to improve extension of the elbow joint. All right, let's move on to question number 3. There's a poll. Take about 10 or 15 seconds to finish up. And we can take a look at how everybody responded. So most people chose Phelan's test, and let's go ahead and review these and talk about it. So this PT is examining a patient who's having difficulty gripping a ball. So we know that they have some motor involvement. Grip strength is going to be decreased. There's dysesthesia distal to the wrist produced by tapping over the carpal tunnel. And of course, what is the name of that special test? Y'all go ahead and chime in the chat box and answer that one. What is this special test? Okay, good. So thank you, Maddie. Thank you, others. So that's Tinel's sign. And then what it says, and this is where it may be a little bit of a tricky question, but better that you see a question like this today for the first time than actually on the NPTE. And yeah, let me go back again, just with that timer getting ready to kick off. The next part says, the tricky part says maximally flexing the involved wrist. So that's this, right? So maximally flexing the involved wrist produces numbness in portions of the thumb, index, middle, and ring fingers. So that median nerve distribution. But what is that test? What is that action? That is actually Phelan's test. We have already done Phelan's test. So Phelan's test is not going to be the correct answer on this one. We have done Tinel's and we have done Phelan's. So it says when performing a standard differential diagnosis, which other tests should be done? Again, for those of y'all that have attended our course, you've seen this question before, but the idea, what we were going for here, and actually let me run through the rest of the answers. So Phelan's has already been done. Finkelstein's would of course be for Decker-Vein's tenosynovitis. Allen's test, and what I hear a lot of students say is that Allen's test is done for thoracic outlet syndrome. You can do Allen's test with, in patients in which you suspect thoracic outlet syndrome, but Allen's test is really just it's a test of distal arterial patency and distal arterial blood flow. And it is not pathognomonic for thoracic outlet syndrome. That is, if somebody has a positive Allen's test, that doesn't mean they have thoracic outlet syndrome. It could be a finding with thoracic outlet syndrome, but it is not diagnostic of the disorder. And then the retinacular test would be looking at whether limitation of motion in one of the interphalangeal joints with the IPs, is that due to intrinsic or extrinsic reasons. So for the person who wrote this question, and what we were going for with it is that anytime somebody has distal sensory and motor impairments, we think about the patient with diabetes, for instance, we not only want to do a neuromuscular assessment, we want to think about doing a neurovascular assessment. And so the correct answer on this one is Allen's test. All right. So here are some of those special tests. This is from our review and study guide. Uh, um, I suspect a number of you have our review and study guide, and some of the special tests that we just talked about are summarized here. The authors of the musculoskeletal chapter put together, Brad Traeger and Mike Crowell put together a number of really nice summary tables. The Allen's test is shown down in the bottom right of this slide, right, where we compress the radial and ulnar arteries together, have the patient kind of pump their fist or hand about 10 times, relieve pressure on the radial artery, and hopefully see good color return to the hand, so good arterial refill of the hand. And then we repeat the procedure, and then the next time we relieve or release pressure on the ulnar artery. And so again, that's going to be a measure. Allen's test is a measure of vascular status, distal arterial patency. And so yeah, with that, we want to think about, with that question, we want to think about anybody that has distal sensory and motor impairments that we want to consider doing a neurovascular assessment with them. Some of the other answer choices here, Finkelstein's test is shown here, retinacular ligament test, again, really looking at whether the limitation of movement in the interphalangeal joints, is that due to intrinsic reasons, or is it due to maybe extrinsic tendon tightness? So does Phelan's test not include overpressure? Not to my knowledge, it does not. You have the patient position like this, or maximal flexion, right? And then you're going to hold it there for a period of time, 30 seconds or a minute, and see if that reproduces the patient's symptoms. So there may be a variation of it where you can do some overpressure, but otherwise, no, you do not need to apply overpressure to execute Phelan's test. All right, let's move on to the next question, number 4. Go ahead and take 10 or 15 seconds to finish up. All right. And see, on this one, it looks like most of y'all were deciding between a scaphoid fracture and skier's thumb and This is another one of those direct access PT clinic. I mean, but you could very well see somebody with this kind of injury in in a typical outpatient orthopedic clinic as well, outpatient physical therapy clinic. And so some of the key findings on this one, we know that this person had a fall. They injured their thumb, and they had this fall that they sustained while skateboarding. They talk about an inability to grip. There's some swelling, there's some bruising or some ecchymosis. But I would say really the key finding on this one is valgus instability of the metacarpophalangeal joint. So when we do that valgus stress test of the thumb at the MCP joint, that would reveal what the problem is. And in this case, it's going to be skier's thumb. So skier's thumb, and you all may have heard this called gamekeeper's thumb before, because gamekeeper's thumb would be and this got it. This describes more of a chronic injury. What happened? We think in your or how it got its name back in the days where there was a gamekeeper maybe in Europe or in somewhere in England that was the person that was taking care of the game or the fowl, and they would get a hold of the duck's neck or the chicken's neck or whatever the case may be, and they would break it before preparing it for a meal, and they would get their thumb caught in that action. And so gamekeeper's thumb is the term that is typically applied if there's this repeated micro trauma that happens that leads to instability of the joint. Skier's thumb is the term that is applied when we're thinking about more of an acute injury. So that person that falls down, they got the ski pole in their hand and they fall and they have a traumatic injury, a traumatic acute injury to the thumb, or in this case, the scenario was somebody that was skateboarding and they had a similar mechanism of injury. So this is another one of those injuries that is described in this paper. Again, I think it's an awesome paper, and so we've got got the anatomy that is involved. It's an injury that involves the ulnar collateral ligament of the metacarpophalangeal joint of the thumb. And I'm sorry, let me go ahead, and I see some of y'all are chiming in with some answers or questions and everything. Yeah, and so I don't have I'm sorry, Camille, I see you asked me that. I'm going to share my email address with y'all later, and some of your questions I can answer personally a little bit later, but I do not have an image of what you were actually asking for, not as part of the presentation. And let me see. Then there was another response. I want to make sure that I got. So check out Clinical Files podcast by Dr. Cal Rice. Heather, I'm not sure, what was that in response to, if you don't mind answering that. Oh, got it. Okay, got it. So anyhow, just another image here that shows the injury that would be involved, the anatomy that would be involved. So the ulnar collateral ligament of that first metacarpophalangeal joint. And this is certainly something that would require attention to, it would require attention to by an orthopedic surgeon, by a hand surgeon. We'd want to make sure that those folks get referred in a timely manner as well. So, all right, we'll move on and on this one, so yeah, 74% of y'all got that correct, so well done. And we will go ahead and move on to question number 5. All right, here's the poll. Go ahead and finish up. All right. And yeah, it looks like just about everybody's responded to this one. So let's bring in some of these highlights. We know this patient has carpal tunnel syndrome. It's always nice when they tell you the diagnosis, and then you got to figure out what the appropriate intervention is going to be. The patient's chief complaint is intermittent hand paresthesias, which affect their quality of sleep, which is the best initial intervention for this patient. 94% of you chose number two, and that is indeed the correct answer. And there, y'all may be familiar with there's the clinical practice guideline for carpal tunnel syndrome, and I've got part of it. So got part of it referenced here. For those of you that have our review and study guide, the big book, then yeah, for those of you that have the review and study guide, you know that we have uh, virtually all of the JOSPT published clinical practice guidelines summarized in chapter 2 in the musculoskeletal chapter. So again, Brad Traeger and Mike Crow have done a wonderful job of taking what can be really, really long clinical practice guidelines and summarizing them into about a 1 page or half-page summary. And in as it relates to this question, right, we can see that there is a moderate strength of recommendation, so level 2 or grade B, to use a neutral position wrist orthosis at night. So you are going to see questions on the NPTE that are directly related to the evidence, and there's really not a better place to go for that for one-stop shopping than the clinical practice guidelines. Now, a question that I hear from students all the time is, are the clinical practice guidelines, are they testable on the NPTE? And the question, I mean, the answer is that they per se, the CPGs per se, are not necessarily testable. They're published in journal format, and the examination that you're going to take is textbook based. But most of the information that is in the CPGs has already been published in your textbooks, in Dutton, in McGee, in other textbooks. And so what I encourage y'all to do is, pretty much anything you want to know about management of the person that has carpal tunnel syndrome, there is a clinical practice guideline for it. And if you have our review and study guide, then it's going to be in chapter 2. The same thing with low back pain clinical practice guidelines, or neck pain, or adhesive capsulitis, or knee injuries. So there's a number of wonderful ones. And so I encourage y'all to study those clinical practice guidelines in preparation for the examination. Similarly, if we take a look at some of the other answers that were part of that question, it says we should not use, there's actually evidence against using things like iontophoresis or ultrasound. And let's see, what else to tell you about that? Oh, as far as the CPGs go, for what we have done in the review and study guide, and I believe this will be true, that most of the questions, if they're based on the evidence, would be based on level 1 or 2 evidence, or grade A or B. And so that's certainly what where I would focus my attention. And what we have done is all the grade A recommendations and all the level 1 evidence we have highlighted in bold font within the boxes, like the one that you've seen right here. The So that was a question, of course, about carpal tunnel syndrome with the median nerve. We can think about some other things like pronator Terry syndrome, anterior interosseous nerve entrapment, or that syndrome, which is really involves muscles only. There's not a cutaneous distribution, cutaneous sensory distribution for the anterior interosseous nerve. With the ulnar nerve, we think about cubital tunnel or entrapment or compression at Guillen's canal, radial nerve, radial tunnel, and of course there's supinator syndrome or posterior interosseous nerve syndrome. And so I'm highlighting these because, and as I often teach students during our 2-day course, when we're thinking about these musculoskeletal or neuromusculoskeletal disorders that are distal, say from the elbow on down, a good chunk of those questions are probably going to be based on either nerve disorders. What else have we seen tonight? Fractures and ligament injuries, tendon injuries, and so certainly be prepared for some of these common mononeuropathies. And the most common mononeuropathy is going to be carpal of the most common mononeuropathy is carpal tunnel syndrome. Okay, let's go ahead and move on and take a look at question number 6. Here's the poll. All right. Let's go ahead and take a look at how everybody responded on this one. So, sorry, I made a cut a couple of you off a little bit early, but it looks like almost 80% of y'all chose the answer of wrist extension on this one. So this patient is referred to PT after sustaining a mid-shaft fracture of the humerus, and as far as anatomy, what we want to remember with the mid-shaft of the humerus is where we find that spiral groove or radial groove. So the radial nerve is going to wrap right around the the mid shaft of the humerus as it runs from posterior and wraps around to anterior. If it was up by the surgical neck of the humerus, we would think about the potential for a concomitant axillary nerve injury, right? But in this case, mid-shaft fracture of the humerus, there's a potential for a radial nerve involvement, and indeed that numbness on the lateral side of the dorsum of the hand. So on the thumb side, on the dorsal side of the hand, superficial radial nerve distribution suggests that the radial nerve may be involved. And so when we're doing our strength testing, then wrist extension. All of our wrist extensors are innervated by the radial nerve or a branch of the radial nerve. So that is the correct answer, and that would be the appropriate group of muscles for us to suspect weakness in. And the others, so if we look at, let me go ahead back to this real quickly. So with thumb adduction, so we think about some of the hand intrinsics, the adductor pollicis being involved, innervated by the ulnar nerve, deep branch of the ulnar nerve. Opposition, also going to be innervated, well, kind of a combination of the, we would have recurrent branch of the median nerve, okay, is going to be involved there. And then wrist flexion is going to be a combination of both median nerve and ulnar nerve. And let's see. So the question, so Mina, you were saying, is it not loss of wrist extension? Well, it's wrist extension weakness. That's what we've been looking. If we're doing a manual muscle testing, then now if it's a complete lesion of the radial nerve, yeah, they probably would not be able to even be able to initiate the action of wrist extension. But it doesn't tell us that. All we know is that there's some sensory involvement, which makes us think about the radial nerve. And so if we did find weakness in a muscle group, it's going to be in the wrist extensors. So here's just a quick review of the anatomy. You can see right here, so the radial groove, also called the spiral groove, is where the radial nerve is going to wrap around. It runs from posterior. This is a posterior view of the humerus. From posterior, in between the medial and lateral heads of the triceps brachii, and then it ends up emerging again distally in between the brachioradialis and the brachialis at the elbow, before innervating all of our wrist extensor muscles. And then what is shown in this lime green color on the right side, this figure from Gray's Anatomy, that'd be the distribution of the superficial radial nerve. So radial nerve involvement, a couple of quick ways. Let's see, if we were working somebody, if we were working with a patient in which we suspected that they had a fracture that involves the midshaft of the humerus, maybe we got them stabilized and they're in a sling and easy. So let me back up a little bit so y'all can see me. So I'm stabilized, maybe I'm in a sling. A couple of quick, safe ways to assess for the integrity of the radial nerve. Let's check the sensation on the dorsum of the hand on the thumb side. And the other thing that we could do, we got their upper extremity stabilized. We could just ask them, can you go ahead and bring your knuckles up towards the ceiling? Can they extend the wrist? And those would, if they can't, if we got both of those compromised, then we would be really suspicious of that radial nerve lesion. All right, a couple more questions to go here. Okay, go ahead and finish up. All right, so in this question, it says this patient was referred to PT. They have a diagnosis of boutonniere deformity. And so we have to identify what is the cause, the primary cause of that deformity. And for those of you who have taken our 2-day prep course, you may recognize this question. Median nerve lesion, number one. So if I'm thinking about a deformity, right, the only deformity that really comes to mind if in somebody that has a median nerve lesion that I would consider would be like profound atrophy of the thenar eminence. Sometimes we call that simian hand or It's called APAN, right? That flattening that happens because of the profound atrophy of the muscles of the thenar eminence. But that is not what is being described here. With the boutonniere deformity, we're thinking about the extensor mechanism, the extensor apparatus. And so number one is probably the first answer that I would eliminate as I was going through and answering these questions. Number two says rupture of the terminal tendons of the extensor digitorum. So I don't know if y'all can see what I'm doing with my finger here, right? But if I rupture the terminal tendons of the extensor digitorum, then I am not going to be able to extend my DIP. Okay. And so that would be, somebody answered a little bit earlier when we had the question about Jersey finger. They chimed in with, yeah, mallet finger, exactly. Amanda and Alyssa, that's exactly right. This would be, or what is number two describes, is going to be mallet finger. The correct answer on this one is going to be number three, which more than 90% of y'all chose. So awesome job on that. So a rupture of the central slip of the extensor digitorum is what is involved. Quick review of the anatomy. When our extensor tendons, when they cross the metacarpophalangeal joint, what they do is they split into three bands. So they'll split into three bands, and the central band or the central slip attaches at the base of the distal phalanx. The two lateral bands, even though one's medial, one's lateral, we call them lateral bands, and they are going to converge at the base of the distal phalanx, and they are going to form what we call the terminal tendon. And so if we lose that central band, that where the central slip attaches to the base of the distal phalanx, then that PIP can pop up like this in between the two lateral bands. So that's where we get the name boutonniere deformity, just like the boutonniere on a lapel. That PIP pops up between the two lateral bands. So Gabby, I don't know which part you want me to repeat again, but I'll repeat the anatomy part, and that is that the extensor digitorum tendon, when it crosses the metacarpophalangeal joint, it splits into three bands. It trifurcates. The central band attaches to the base of the middle phalanx. The two lateral bands run around and they converge and attach to the base of the distal phalanx. They form the terminal tendon, and it's when the terminal tendon ruptures that you get mallet finger. Number three, the answer, so that's boutonniere deformity. Number four is swan neck deformity. So the laxity of the transverse retinacular ligaments, we're going to see those in this image that is coming up right here. So those transverse retinacular ligaments, they run from the extensor mechanism around anteriorly, around the anterior aspect of the joint. We can also get a swan neck deformity in somebody that has had a volar plate injury, right? So essentially what happens is the joint is going to bottom out or it subluxes anteriorly, and that's what leads to this swan neck type of deformity. So the boutonniere deformity is at the top of this image, swan neck deformity at the bottom. Hey, while we're looking at these, what disease process can lead to or affect and lead to good? So somebody else, RA, right? We think of with RA, we think of ulnar drift, but we can also see some of these tendon injuries because rheumatoid arthritis affects all those peri-articular tissues, which is why like rheumatoid arthritis can lead to instability of the upper cervical spine because it can affect things like the transverse ligament of the upper cervical spine, or alar ligaments and some of those stabilizing ligaments there. So well done on that. And then here's an image that involves mallet finger. Okay. And then so Maddie, you can't just drop that it's on it without explaining it. So burp is an HBO. What are those? And I'm assuming you meant good mnemonics. And I'm glad that you spelled mnemonic correctly because almost everybody spells it like pneumonics or like pneumonia, right? But mnemonics is exactly the way that you spelled it. Would you like to share that with us? And if you want, you can go ahead and type it out in the chat box, and I'll go ahead and continue with the explanation of these images and everything. So um, let's see. So we got mallet finger here. We've got the so boutonniere RA only and affects the PIP. So boutonniere RA PIP. So burp. Okay. All right. And then I'm waiting for HBO. Let's see what that is. So thenar eminence atrophy in this person that would have carpal tunnel syndrome, or it was taken from a patient that had carpal tunnel syndrome, and they have this profound thenar eminence atrophy. I mean, you can see the outline of the bone right here, right? So HBO, Hebernins and Bouchard's for nodes for OA. Okay, I like that. Maddie, I hadn't heard that before. In all the years I've been a PT and I've been teaching this stuff and everything, so I may have to steal that if that's okay with you. So, so burp is with okay, Bouchard's okay, got it. Yeah. So we'll go back and thank you. Yeah, thank you for sharing that. So yeah, great job on this question as well. We are down to our final question of the evening, and here it is, question number 8. Heather, I'm gonna answer your question at the very end. So we'll answer this question and then I'll come back and we'll talk about the hand of benediction and yep. Yeah. Okay, I'm sorry. I'm sleeping on the job here. Here's the poll. Thank you, Katrina. Yeah, y'all go ahead. I'll give you a few more seconds to get your answers in since I didn't get it up quickly enough. And yeah, let's go ahead and start taking a look at some of the key findings here. Hopefully everybody's had a chance to answer it. Most of y'all are thinking that we need to immobilize this person. And here's the question that involves the Fouche mechanism of injury, palpation in the anatomic snuff box, and at the palmar aspect of the base of the thumb. What is right there at the palmar aspect of the base of the thumb? Scaphoid tubercle, right? So in the anatomic snuff box, and then also yeah, so carpometacarpal joint is gonna be there as well, Katrina. But combined with the fact that they have palpation tenderness in the anatomic snuff box, and our scaphoid tubercle is going to be right there at the base of the thumb. We're thinking this person has a scaphoid fracture, and so if we, somebody presents like this, they have that mechanism of injury, and they have the palpation tenderness and the findings the way that they're described here, then we're going to immobilize them and we're going to get them referred to orthopedics. And so great job on this. And so yeah, so Fuchs mechanism, yeah, scaphoid exact numbers. I would be thinking for the carpal bone, I would be thinking, scaphoid's got to be towards the top, but we can have lunate injuries, and with the lunate, we can remember Vizzy and Dizzy. We can have instability that involves the lunate, and so those two for sure. Those are going to be the two carpal bones that are most often involved with a Fuchs mechanism. This is an excerpt we have in chapter 2 of our musculoskeletal chapter, and really throughout the book, actually, we have a number of red flag boxes, and the whole issue is we want to make sure that timely diagnosis and management of a suspected scaphoid fracture is critical because of the potential for avascular necrosis. And just to review that anatomy real quickly, that is, here's the scaphoid bone, and the blood supply is from a branch of the radial artery that virtually in all of us enters the distal aspect of the scaphoid. So if we have a fracture through the waist right here, the equator, if you will, of the scaphoid, then there's the potential for there to be avascular necrosis that involves the proximal pole of the scaphoid. And so, yeah, we got to pick up on this. We got to be good at doing that. And we've got to make sure that we get these folks referred as soon as we recognize that they do have a scaphoid, potential of a scaphoid fracture. Okay, Heather, I haven't forgotten about your question, but y'all did a great job answering these questions, by the way. Awesome. I saw a lot of really high numbers. And I think that also reflects the fact that, those of y'all are going to be taking the exam next week. You're ready, right? You're ready for questions like the ones that you saw tonight. Even if you've seen some of them before, that's okay. It's a matter of getting our reps in and reviewing and still answering the questions correctly. Yeah, Heather, I'm going to answer your question, but y'all take a look at this slide real quick. Instant diagnosis. Chime in the chat box. What do y'all think that is? What would the diagnosis be here? And let me go ahead and see what everybody's saying. So yeah, olecranon bursitis. So olecranon bursitis is what we're looking at here. Do y'all know the eponym? Do y'all know the eponym for the nickname for olecranon bursitis? It has to do with this season in your lives, where you are right now. Right? So student's elbow, that's it, Emma, that's exactly right. So student's elbow from kind of, right, we got our elbows on the desk or wherever. And awesome. Okay, now let me come back. We're gonna, we're kind of wrapping up. I'm gonna answer Emma's question, and it may have time for like one more, and that'll probably be it. We try to keep these sessions to about an hour, but if we go to an hour and 15 minutes, that's all right. So Heather, since both, with APAN or simian hand, what we're looking at would be involvement of recurrent branch of the median nerve. And so carpal tunnel syndrome could be pronator Terry syndrome as well, but we've got compression of the median nerve, and it involves, so we would have that profound thenar eminence atrophy. You could potentially get a lesion that involves the hand of benediction. So let me say this. Part of it has to do with the chronicity or the acuity of the injury and everything, the acuity of the condition. You would have to right, to get to the point where there's this profound thenar eminence atrophy to the point of ape hand or simian hand, then you would then that compression of the nerve would have had to have been there for quite some time. All right, so that's one thing to take into consideration. The other thing, and it's interesting with the hand of benediction, most of the time people think of the hand of benediction, so this kind of positioning is involving a median nerve lesion. But there are some references that that say that, with ulnar nerve lesions, you can see a hand of benediction. The important thing is, or yeah, Pope's hand, or whatever nickname we're going to call it. But the important thing to remember, if you see somebody, right, if you see somebody that has this type of posturing, what we got to take into account, and what's an important consideration, is, did we start with a closed fist and ask somebody to open up like that, or do we start with a hand that is open and ask them to make a fist? In which case, if we start with the palm open, and I'm kind of picturing me, maybe, I've got the patient's hand or outstretched across the plinth or the treatment table from me. But if we start with a hand open and we ask them to make a fist, if they cannot do that, right, they can do it with digits 4 and 5, and the flexor digitorum profundus, for those two, are going to be innervated by the ulnar nerve. All right, then in that case, they've got that median nerve lesion. Okay. If we start with a closed fist and we ask them to open up all the way, and it looks like this now, right? And actually, we're starting to get into more, they can extend digits 2 and 3, but they can't fully extend digits 4 and 5. Then we're looking at an ulnar claw hand deformity. Okay. But what my whole point for kind of discussing that is that ulnar claw hand, if all you do is snapshot in time, is look at something like this, that ulnar claw hand, which is here, looks a whole lot like the hand of benediction. We got to know the point where we started. Do we start with a closed fist and we're trying to open it up, or do we start with an open palm and then we're trying to close it? Okay. So, Heather, going back to your question, an important consideration is going to be the acuity of the injury. We're really not going to see that ape hand or that profound atrophy that involves the thenar eminence until a little bit later in this stage. But you're saying, what are the major differences between ape hand and the benediction hand? Two different special tests, right? They're really going to be two different special tests. One is observation, where we look for that profound thenar eminence atrophy. The other one, the hand of benediction, what we are doing is asking somebody that starts with an open palm to make a fist, and they can't do it because the innervation of the flexor digitorum profundus to digits 2 and 3 is just, it's compromised. It's not there because median nerve is going to innervate flexor digitorum profundus to digits 2 and 3. Okay. Let me see a couple of other questions here, and I will answer your questions. I do want to remind y'all too of the resources that are available to you on TherapyEd's website. So this probably applies more to folks who are going to be taking the examination a little bit later, but we've got the app, of course, our online office hours. This is the last one before the exam next week. So absolutely, good luck. Best wishes for success to all of you who are going to be taking the examination next week. Y'all got this. And there's the prep course, there's the review and study guide. So I just want to make sure that y'all are aware of those resources. And then as far as the other questions that go, so Josh, will last week's lecture be posted to the YouTube channel before next week? I will talk to the folks in Therapy Ed's headquarters and see if they're going to be able to do that, try to push for them to be able to do that. So we'll hopefully that'll happen. And then let's see. So Heather and Katrina, hopefully that answered the question for y'all. The next online office hours are going to be about, so we do them for about the 6 to 8 weeks leading up to each iteration of the NPTE. So it'll probably be mid to late August before we resume online office hours again. And let's see. Yeah. So thank you all for joining us tonight. Best wishes again to all of you who are going to be taking the examination next week. And for those of you who are taking it later, hopefully we're going to see you at one of the upcoming online office hours at our 2-day prep course or somewhere else along the line. So good night. Y'all be safe. And again, best wishes for success on the NPTE.